Hello and welcome everybody from Berlin once again to our Quintessencial Tuesday, coming to you live from Berlin, from Mainz and from Bern. Today we have the opportunity and the pleasure to welcome once again our host Dr. Chris from Mainz, who will join us in the moderation and the discussion, and Professor Danny Buser from Bern, who we all know very well, and we are glad to call him not only a cooperator with us, but also a friend over many, many years. So once again, the house rules today is please use the F&A tool and the F&Q tool if you want to ask questions. We will try to answer them live together with Professor Buser after the lecture. And of course, if you have a drink, take a drink and enjoy the drink. And for now, I will give to Chris, who will continue on. I wish all of you a great evening.
Yeah, thank you, Christian. Hello, dear friends of dentistry. Welcome to our final webinar for this year. It was a long year, but don't worry, Christian and me, we had so much fun that we are really thinking about to continue this for 2022. We have so many speakers up our sleeve that we just can't stop that. As usual, you will find more details about this on Facebook, on Instagram, and on the Quintessencial homepage. And it was a great year with these webinars, but what a year. We started in the middle of Corona, and we all thought that Corona will be over till we stop our last webinar, but not even close to that. It has never been as bad as it is now in Germany. We have some parts of Germany where our incidences are up to 1,000. It's crazy now. You can only go to a restaurant or to a hotel when you're vaccinated. And perhaps they think about the next lockdown, but I have the feeling that there's currently a little perplexity in this crisis, and that there's a simple lack of experience how to manage that. In our webinar, we will prove exactly the opposite. Professor Danny Buser gives us 30 years of experience in GBR. 1993, he published his first book. And I don't think that it's necessary to introduce Danny Buser. He's a veteran in implantology and in demand as a speaker on all stages of the world. His new book has been now on the market, I think, for 10 days, you told us. And of course, it will be obtained from Quintessence. And Christian will put a link of that in our chat. And I promise you, it will be out of stock in a short time. So be fast to order. Christian will place the link and the title in our chat. And now I give you 1 hour of experience with Danny Buser from Bern, and it's a real pleasure to have you here as a speaker, and the stage is yours, Danny.
Okay, Chris, what a pleasure for this kind introduction. Also, Christian, it's a big pleasure to be back in the Quintessence family. As you just said, you see, it's my relationship with Quintessence started in the early 1990s, and then the first result was the GBR book that came out in I think it was January 94 or end of 93, and of course it helped me to establish my career on a global level, and I'm very, very happy with this collaboration with Quintessence. Now let me share my screen so we can start with my lecture. And here we go. See, the topic has been said already. Of course, we talk about the GBR procedure 30 years, which is the title of that book. And I will talk quickly about development, but then the progress and the state-of-the-art GBR procedures in daily practice. I will show you that we have made tremendous progress with GBR in these 30 years. And that we use it today, you see, and achieve excellent clinical outcomes when it's applied correctly. So I give you greetings from my hometown, Bern, which is a very small and cozy city, capital of Switzerland. You see, not too far away from the famous Swiss Alps. You see Jungfrau, top of Europe, also that's 90 minutes away from Bern. And I have to say, I'm not a Bernese, you see, I was born about an hour away. but Bern is a very nice city to live in. I'm here with my family, with my 3 kids. Of course, they're all Bernese kids now. And that will be the beauty of next year. We're going to get 2 grandchildren first now. And I'm very excited about this new phase of our lives, of my wife and myself. So I have been working at university for 40 years. This is the School of Dental Medicine in Bern, actually top 10 university in the field of dental medicine. Next door to the left, you see a new research building. This is called SITM, Swiss Institute of Translational Medicine, and I'm chairman of the board in that building. And I'm very active in that building because translational research, that's all about what I did in the past 30 years, 35 years. That means how to bring innovation quick to the patient so the patient will benefit. And the GBR is a fantastic success story exactly in translational research. You see, I decided 9 months ago that it's time to say goodbye to university, and I moved into a private clinic. I'm working there only 3 mornings, that means 30%, Center for Implantology. This is a former postdoc student of mine who has established here a fantastic private clinic with 6 dentists. This is the new way of dentistry. You see, since we have such a high percentage of females, nobody wants to work 100% and run a private office on her own or his own. You see, now I really love to be there. And my main activity today is knowledge sharing. You see, I had a fantastic mentor, Professor Schenk. We'll talk about him. And he did exactly that one when he was retired. He shared his knowledge to all the youngsters. I was one of them. So I profited many times. And we learned so much from him for GBR. And so I'm going to do the same now. And for that one, I've established with my dear friend, really good friend, Tony Sculian, this Booth and School Academy for continuing education courses using the streaming technology. You see, we are offering a master course. I will come back to them to do this knowledge sharing on a global aspect. Okay, we also learned to use social media channels. You see, Facebook I had since 2016. Now we are close to 13,000 group members in that Facebook group. You see, Instagram, more than 12,000 followers. LinkedIn is growing now. You see that we are using them, of course, also to promote now the book. And you see, you have a tremendous impact on this one. You see, this is a post I did on our Facebook group. I think 3 days ago or so, not too long ago, you see, and you have a fantastic global reach to the dental professionals, you see, same on Instagram. And we are just promoting on these channels our continuing education or new papers or like a new book, whatever. And this is very interesting. Now, these are the 5 topics I will talk about. So we start with a short introduction very quickly because we have only 1 hour. You see, I want to show you that today implant therapy is highly predictable. We are in a phase of routine application for many, many years. I always say around millennium change was the change into routine application. And since then, we try to make these treatments more patient-friendly, reduce invasiveness, whatever you see. But we know if we follow the rules, if you follow the evidence-based protocols, we can get excellent outcomes. And you see, and when I look at the publications from our group, you see Bern has a fantastic documentation on long-term studies. These are 3 of my group. We published between 2012 and 2018. And you can see that the survival rate are all above 98%, success rate between 95 and 98% when we apply very strict success criteria. And that's very important when I see patients today. You see, I treat about 3-4 patients a week that I tell them, look, the risk to lose an implant in 10 years period when I treat you with our procedures, then less than 2%. And this is excellent, very simple to say. Okay, this is the kind of results we want to have. You see on the left side is a 10-year follow-up with a bone level implant. We're going to see that later on. And then the other ones are actually older cases, you see, up to 25 years. So these cases were all treated with Professor Belzer. You all know him. He was in Geneva, then 10 years in Bern as an emeritus professor with me. And you see, that's what we try to get. We want to have successful outcomes. We want to have long-term stability. That's the key. We're not shooting for short-term results. And then after 3 to 5 years, we start to see problems and so on. Okay, what I learned is that from a surgical point now, only surgical, there are 4 key factors for long-term success. One is that you have to utilize an implant of sufficient length, diameter, strength, shape, and the micro rough surface. That's very important, but I will not go into the details of that one. Then you have to put that implant in a correct position. This is often called restoration-driven implant placement by Garber and Belzer, paper 96. And then this is the most important one when we talk about GBR. The implant must be completely or circumferentially embedded in healthy bone at completion of healing. So when we have healed sites, you have to have sufficient thickness of lingual and buccal bone wall. If there is a defect, please augment that defect, otherwise don't place an implant. And last but not least, the tubing keratinized mucosa. The topic today is the 3rd point, not the other 3 ones, you see, the 3rd point. Now, when we place implants, we have 2 different scenarios. We all started with healed sites, Bronner, Mark, Schroeder, you see. When you pull the tooth, I had to wait 6 months, and then often I couldn't place it because everything was at profit, you see. So there you have 3 scenarios, and then of course post-extraction sites. That means here we differentiate thick wall phenotypes, thin wall phenotypes, or no facial wall due to infection. When you look at these 6 different scenarios, 5 of them you need a GBR. When we discuss bone augmentation, we can also discuss the categories of different bone defects, because we can have a horizontal bone defect or a vertical bone defect. Now, today we'll not talk about vertical bone augmentation because that's very rare. That's less than 1%. But I talk about horizontal bone augmentation. And here you can have 3, 2, or 1 wall defects. Very important for the case selection. The other one is when we go for post-extraction implant placement, we have different treatment modalities, also placement options. So the immediate implant, that goes back to the 1970s. You see by Professor Schulte from Tübingen, you see it was a ceramic implant at that time, you see. Then the late implant placement, that was the Bronnemark and Schroeder approach, you see. And then we established with ITI in between an early placement protocol, it was often called, which is complete bad name, you see, delayed immediate. Early, that's really shows it clearly. We pull the tooth, we wait a few weeks, sometimes 3 to 4 months, and then we place the implant. So the objectives I said already, you see, we want to have successful outcomes from an aesthetic and functional point of view, and we want to have a low risk of complications during healing and during function. So these are often called primary objectives. Then we have also secondary objectives, and that means we want to do these procedures today with the least number of open flap surgeries, least possible pain and morbidity, short healing periods, overall treatment periods, and so on, you see. And that's very important because this is the progress we have made in the last 20 years. We have been able to reduce the number of surgical procedures because we do most of our procedures with a simultaneous bone augmentation. Not all of them, but most. We could reduce morbidity. You see, avoid the bone harvesting from the chin. We do most often these bone augmentation without any use of connective tissue grafting, you see. So then the patients don't have to have a donor site in the palate. We are able to reduce healing periods, and by using digital technology, we could also help to improve implant surgery. Now, that's not the topic today because I will not talk about immediate implants because that's not a GBR procedure, because there I use computer-assisted surgery as a routine today. Okay, now 30 years of GBR. development and fine-tuning phase, I often call it. And here we go now to the GBR book. This is the book that came out, 3rd edition, and look the list of authors. I mean, this is world-class. These are the best on the planet. In particular, with this international, we had the Bernese group in the beginning, and then you see here Stephen Chen, Sasha Jovanovic, Isabella Rocchietta, Frank Schwartz, Istvan Urban. You can't get better authors and master clinicians for contribution like this one. So when we talk about these 30 years of progress, you see, this is the chapter 1. You see, I've written that one that gives a very nice overview at all the critical developments. And you see, this is actually the table that has been utilized for the book. So you see the development phase started in 1988 when I did the first GBR procedure on the globe in October 88, and took about 10 years, almost to the millennium change. And then routine started, and then the fine-tuning period. And you see, when you look at this, then you can divide it up. You see different phases, all underlined by clinical research, a lot of this translational research, as it is called today. So let us start with the development phase. And of course, in that phase, you see GBR technique was developed, you see, with this principle of physical barrier, excluding the soft tissue cells from the periosteum, from the connective tissue and epithelium, and give then the bone-forming cells, which are actually vascular cells, and then the osteoblastic lineage, you see, give them exclusive access to this protected or secluded space, as it was called. You see, these are the first papers that were published. Of course, first were 3 animal studies from the Gothenburg group with Neumann. Christa Dahlin was the first author, a postdoc at that time. And then the Schenk paper was then really a sensation because it showed how bone heals. And then, of course, first clinical case reports. So I always give great credit to Professor Schenk. You see, was my second mentor after Professor Schröder, Bob Schenk, who passed away 10 years ago now. And this is the very famous landmark Rabinoichomi that was published in 94, was the basis of the first GBR book because it showed beautifully, you see, how the bone heals. You see on the right side, a 2-month specimen where you see this woven bone, a huge amount of blood vessels, and then 4 months, the maturation. Now you have all of a sudden, you have a cortical bone, and in the central portion, you have less bone than at 2 months. So this is what actually Bob Schenk helped us to understand what really goes on underneath the membrane. So after 5 years, I remember very well, in 94, we had a meeting in Arizona, and you see here the youngsters, the 3 young boys here, together with Bill Becker. You see, this is Sasha and Massimo and myself. We had a meeting and said, where are the problems? And we identified, of course, that we had a lot of membrane collapses. We had a lot of infections. We always had to do an open flap procedure. And there we said, you see, we need to search for appropriate bone fillers, and we have to search for alternative membranes that should not be removed anymore. That means a resorbable membrane. So that was then what happened then, let's say, beginning of 96 or so on. So we looked into bone fillers at that time primarily. We also did some membrane studies to move on to an alternative, which was then a collagen membrane. You see, Gore-Tex membrane lost its dominance. Gore-Tex is gone anyhow. You see now, PTFE membranes, a very small percentage still used, but most of the membranes used today are collagen-based, you see. But it must be supported by bone fillers. You see, that was the main activity of our group, where Bob Schenk helped us tremendously. Here you see the only 5 of the, I think, almost 10 papers we have produced in 12 years. The first one in 98 came out, and I can tell you Bob Schenk got very excited about it, because we have used standardized bone defects in the mandible of miniature pigs, filled them up and covered them up with Gore-Tex, and then analyzed at different time points and did histometric analysis to see how they stimulate the formation of bone and how actually they are substituted. So these are the two potentials, let's say the two characteristics you have to know about bone fillers. And you see here from two papers by Simon Jensen published in 06 and 09, you can beautifully see what it is. You see the osteogenic potential in all the studies we have done, it's no doubt today, is just with autogenous bone chips or autologous. That means the patient's own bone. And Bob Schenk always said it must be driven by growth factors. I don't understand this too much, but the histology is overwhelming. So this is what you see here. Nothing gets close to it. So if you want to speed up in the first 2 months of healing, you need autogenous bone. When you talk about substitution rate, you see volume stability, then autogenous bone is very poor because it resorbs quickly. TCB the same. And there we learned that DBBM, which is a bovine filler, you see, deproteinized bovine bone, actually this is BioOS, you see has no comparison. You see, it's the best volume stability in all the studies we have done. And therefore, that's the combination we are using. Very clear. Here you see beautiful histology from the Bob Schenk lab at that time. Today, this is run by Dieter Bossart since 2004. And when you read the book, you see this is the chapter number 2. You see Dieter Bossart, a superb PhD. You see a researcher, and he is fantastic. You see head of this lab, the Robert K. Schenk laboratory for oral histology. Okay, what we also learned in that phase, you see that actually we got a three-dimensional radiograph technique called CBCT, and that helped us from a clinical point of view to better analyze the patients to see what's the morphology of the bone defect. So this technology really helped us. We always have used Morita, the best machine on the market. From my point of view, today it's a Meram UX800, also in my new working place where I work with Mark Fry. And you see, we are using them when we have to deal with defects as a routine. I mean, if you have problems, you have not done a three-dimensional radiograph, they're going to hang you up very quickly because then you have not used the current technology available to analyze a patient before you treat. Okay, then something else. In 2005, a huge paper came out about ridge alteration. Came out of the Gothenburg group again by Professor Jan Linde. And you see, this is this famous paper, Araujo and Linde, because that's the best cited paper in the last 15 years, has 100 citations every year. I mean, it's unbelievable. And the impact this paper had, we learned a lot from that paper. It explained many things. And the second paper is for my group. You see, I have analyzed, we have treated 39 patients with 2 cone beams. And then Vivian Chappell was at Harvard at that time, and she came back, then we analyzed it, and then we published. You see, this is a clinical paper. Araujo and Linde is a preclinical paper in Beagle dogs. You see, the clinical paper showed very clearly, if you have a thin facial wall at an extraction site in the aesthetic zone, you're going to lose a lot of bone. So that was an eye-opener, how much bone you lose. You see the median vertical bone loss was 7.5 millimeters. So we know today, you see in a thick wall phenotype, post-extraction, you get a little bit of bone loss because that's the tip only, the peak. But when you have a thin wall phenotype, less than a millimeter in thickness, you're going to lose a lot of bone. You get a flattening, you cannot stop it. And therefore, you got to be very careful. And these are the cases then where you need GBR to rebuild that bone. So we learned also from this paper, also my group, you see Vedrana Braut, that this thin wall phenotype is dominating the anterior maxilla. There's no way. So first premolars are much better, and first molars are even much better in the mandible because there you have a lot of thick wall phenotypes. Many other studies showed the same. So we know today in the anterior maxilla, this is all dominated by thin wall phenotypes. You see, you're going to see a lot of bone resorption, and you better be prepared for a bone augmentation procedure calling GBR. Okay, Then something else also in 2013, finally, the selection criteria for the timing protocols post-extraction have been defined. That was a huge progress. This was based on the current literature at that time and the expertise of more than 100 ITI fellows being present at this consensus was actually in the Kursaal Bern in my Congress Center in Bern. You see, here you see the guidelines for these various treatment protocols have been decided and defined, and you see that's what we are using today. We have clear selection criteria for immediate implant placement, which is used about 5 to 10% in the aesthetic zone. Early implant placement with contour augmentation, I will talk about that because that is using GBR. And late implant placement following socket grafting. This is often used in premolars or molars, because then we don't have to do any GBR procedure. So that's not the topic today. So the middle, you see the middle, the early placement is using GBR open flap procedure, and this is very prominent. What we also learned in the early 2010 is that actually, why do we see such a tremendous positive effect on autogenous bone chips? And this is often called bone conditioned medium. You see, these are all preclinical research, and this is made with cell biology research. And of course, here, a very important role was played by Reinhard Gruber, who, because I hired him from Vienna to come to Bern. He stayed there for 3 years and did a lot of research with our group. And in particular, we looked into these autogenous bone chips. Today, the head of this lab is Asparuhova Maria. And I show you quickly a study that was published 2018, which is beautifully summarizing what you get. You see, this was done with autogenous bone chips from a pork mandible. And then in the lab, they were stored in 2 different solutions, BCM, as it's called, in a ringer solution or ringer solution and blood serum. And then you see that when you put them in there, that you get PGF-beta-1 release, which is a very potent growth factor for the formation of bone within 10, 20, 40 minutes. You see, when there is a combination of ringer solution and blood, you see then actually you see much higher after 1, 3, and 6 days. The BMP2, another very important growth factor for the formation of bone, actually needs more time. So after 1, 3, and 6 days, it's picking up, and there's no difference between the two. That was very important, and you see here the interplay that's from this paper that actually Maria explains. You see TGF-beta, which is a very important recruitment and proliferation factor. That means they are triggering the precursor cells to move into the defect. Whereas BMP2 is a differentiation and mineralization factor for the formation of the immature bone produced by osteoblasts as an osteoid first, and then of course then the bone which is formed in that defect. You see. So if you want to learn about that one, I can tell you this is a fantastic chapter. Biologic power of autogenous bone graft by Maria Asparuhova. You see, first time in that book, and this will be a great chapter for postdoc students in the various programs where they learn about implant dentistry. So what we do actually today is the following. You see, that's what we learned. So when we open up the flap, we immediately collect blood, and then we mix it with ringer solution. It can also be sodium chloride as an NaCl, you see 0.9% sterile isotonic. Then we mix it so it will not coagulate. And then as next, we're going to start to harvest locally, same flap with a sharp bone scraper. I use those of Hufridi. You see, we collect these bone chips. So we don't open up the chin or retromolar or tuberosity or whatever. It's the same flap. So we are not really increasing the morbidity for the patient. So that goes into this. I call it often, you see, the bloodbath. In German language, it's a complete different meaning, Blutbad. And then after 15, 20 minutes, implant bed is prepared, implant is placed, then we take this this fluid you see, which is called bone conditioning, because we have the TGF-beta1 now in that fluid already. And then we activate the second filler, which is DBBM. And we have shown then in some studies that actually this DBBM all of a sudden is biologically active and stimulates osteoblasts and so on. And then you see how this augmentation is done. It's called a two-layer composite graft. So we are layering first the first filler, autogenous bone, the patient's own bone. Second, the second filler superficially, which is DBBM. Then the whole thing will be covered with a collagen membrane, so there will be no need to actually go back in and remove that. So no second open flap, and then a tension-free primary wound closure. On the left side, you see this two-layer composite graft, autogenous bone, first layer, the chips, and then the second layer, DBBM. Okay, now we go into clinical application. Now, of course, this is the majority of patients today, as you will see later, implant placement with simultaneous GBR procedures. And we start in the anterior maxilla, so aesthetic zone. And here, of course, most of the cases I treat today are actually post-extraction sites, as I mentioned already. And here, I only talk about early placement because there we need GBR. I do, with great pleasure, immediate implant placement today, but that's limited to 5 to 10% maximum, and so on. So when we have an extraction, we should know what we are doing. So actually, then you have three options: immediate implant placement, or you do an extraction and a spontaneous healing, because the goal is an early placement. If you cannot do both, then you go and do a socket grafting for a real rich preservation, and then you place the implant after 4 months of healing, 6 months of healing, or even longer when this is a juvenile patient. So today we only talk about the middle, you see, extraction and spontaneous socket healing, you see. And we do that when the facial wall is thin and or when there is no bone due to infection. You need enough bone apically to be able to stabilize the implant at day of surgery, of day of implant surgery. And this is many times the case, that you can do an early implant placement. So from a schematic, these are all original diagrams from the GBR book. We did them in Bern, you see, and many beautiful, beautiful drawings, also digital drawings. And you see here a thin wall, you pull the tooth, you're going to get a bundle bone resorption according to Araujo. You see an ingrowth of soft tissue into this defect, and you get a spontaneous soft tissue thickening, a huge advantage, a huge advantage. See, it's always a two-wall defect. You measure the width of the crest, about 3-4 millimeters below the future implant margin, crown margin. And then there you measure, when you see 6 millimeters plus, you know, I'm going to get a two-wall defect. So here you see how that looks like. You see two-wall defect because the bone grows always from the sideline. That's something we learned from Bob Schenk. And then, of course, we have different scenarios. You see the defect morphology really matters. That means the width of the defect is the most decisive, and the depth of the defect. The height doesn't play a role at all. So the depth is important. You see, if it's very superficial, like the bottom right, see it's borderline. Because then the stability of the filler applied is then not so clear. If it's narrow and deep, like the upper left, you see then the applied autogenous bone chips are very stable because they cannot move. So, okay, so this is then the augmentation, what I said before, and we do a local contour augmentation. So we over contour. We should not be unrealistic. We will not get the entire volume, you see, because we get formation of bone, and as much as the bone forms into this layer of DBBM, that's what you get. And the membrane will be there for 3-4 weeks maximum. And then you need to have had already the bone formation before then the periosteum hits the newly formed bone there. And the bios will help you to maintain the volume. So we published this surgical technique in 2008 in Dr. Nevin's journal, another Quintessencial journal. You see, that's the case. I will show it to you later on. And I show you now this This case, you see, which was done about 6 years ago almost, 73 years old female patient, you see, has a loss of retention of this canine crown, comes and said, I want to get rid of them. I'm sick and tired to have always these problems with that. And we took a cone beam, and of course, she has no facial wall that is visible, so it's either thin or not even there. But we measure the width of the crest, and this is very favorable, 6.5 to 7.5 millimeters. So when we put a 4 millimeter implant in, we're going to have a very nice deep defect, probably narrow defect. So the tooth has been removed very carefully. Nothing, no socket grafting would be a big mistake from my point of view. I want to get a soft tissue ingrowth, because then you get a spontaneous soft tissue thickening, and that of course is going to help me. It's going to help me then for the implant surgery. You see, then you wait 4, 6, or 8 weeks, depending on the size of the defect, of the entrance of the socket. You see, if it's a lateral incisor or a first premolar, then often 4 to 6 weeks is enough. If it's a large canine or a central incisor, then most often you need 8 weeks to let it heal. So you get an intact mucosa, you get more keratinized mucosa, then the bundle bone has been resorbed when you go back in, and you have a spontaneously thickened soft tissue to work with. It's beautiful. If there has been a fistula or an infection, everything is gone. So all the risk factors are reduced for your implant surgery. So here what you see is now that you do an incision, actually palatal, to go in with the blade to pick up the entire thickness of the flap. So the incision is going to the inner surface of the palatal wall of the socket. And you see beautifully here, this is a thin mucosa, and this is a thick mucosa here. So you have actually an integrated connective tissue graft, you could call it. I tell you bluntly, since 95, 98, 2000, the percentage or the incidence of routine connective tissue grafting has been reduced dramatically. I use soft tissue surgery if it's needed. You see, when there is a lack of keratin mucosa, these are mainly for failed implants in the aesthetic zone with a huge recessions. I know I'm in contrast to many periodontists. They don't like that to hear from me. But you see, I will go on every stage to defend that, because we want to reduce morbidity for our patients. Basta. I'm not treating patients to maximize my income. I'm serving my patient. And I think this patient-centered implant dentistry, that's the buzzword, and that's part of it. So here you see then we collect the autogenous bone. We have this bone conditioned medium. You see, this is the TGF-beta 1 and BMP2, what we already discussed. Then we prepare the implant bed, put the implant in. The positioning is very important. This can be done freehand in a single tooth situation like this, because you have a lot of landmarks in the neighborhood. You can do it with a surgical stand. You can do it computer assisted. But of course, computer assisted will increase the expenses for the patient. So most often in a case like this, I do it freehand. When we have 2 or 3 multiple missing teeth, then I go to computer-assisted implant surgery today. So the positioning has been published in this ITI Consensus Con, another Quintessencial journal. ICHOME, huge citation rate, more than 600 citations, one of my best papers. You see, I wrote it with Will Martin and Urs Belzer, and came out in 2004. You see this concept of comfort zone and danger zone. So the implant shoulder should be in all these dimensions within the green comfort zones. If you handle that correctly, then this is the first precondition to go for successful outcomes. The second one is then to augment the bone at this implant in a correct position. So you see the lady's implant in place, very important. You see it's a bone level implant. That means it's with a micro rough surface all the way to the implant shoulder. So I always place them at least a millimeter below the bony rim, you see, and then I put a 2 millimeter healing cap on. It's like a hybrid design implant now, because then I can augment the bone to the rim of the healing cap. You see that here beautifully, the 2-layer composite graft. And then, of course, the membrane application. I always use a double layer technique. So we have slightly thicker membrane in the critical area, and then a tension-free primary wound closure. Very important. You have to release the flap. Good. 8 weeks later, we do a reopening with a punch technique as a minor procedure. And then patient goes back to the referring dentist, and she got back then here with this final crown. So this is the most beautiful tooth, she says. In the neighbor, she's not concerned about these recessions and adjacent teeth. And you see here the implant well integrated. And here you see the patient again 3.5 years later for the GBR book, because it's a case from the GBR book, I think chapter 8. And you see how great this augmentation worked. Look this one. The peak of the facial wall is 1 millimeter coronal to the implant shoulder. So this implant is fully incorporated in bone with the micro rough surface, because these micro rough surfaces are meant to be osseo-integrated to improve the bone anchorage. When you look, you see what we had. We had a 7-8 millimeter vertical defect, but a 2-wall defect. So beautiful outcome. This is even more difficult. That's a young lady now. You see post-trauma, huge probing depth. So I took the tooth off, only collagen plaque, no socket grafting. Then 6 weeks later, I took a comb to figure out what we have. And now you see from a master class, you see these are the kind of surgeries we show in our master classes. Today, these are hybrid CE courses. That means we have a live stream and an on-demand stream. So you see, we collect the blood, then we collect the bone, and then we put the chips into this blood bath. Then we start to prepare the implant bed. Then you see this is completed. We always freshen the bone defect on the buccal to have nicely freshened bony walls there. And then we put the implant in. Correct positioning, correct axis, sufficient distance to the neighboring teeth, and so on. And then we put here a healing cap on. Let me see if I can show you that. So you see we check everything, axis is checked. And now here you see the healing cap is inserted for the bone application. Then we see now that we take this bone condition medium with a syringe and we put it into the second bone filler, which is the DBBM. So here you see this is actually what we do. Very nicely. Okay, I'm sorry, this was too quick. So, let me go one back. I'm sorry that I made this mistake. So here we are. Okay, so now you see the bone application, bone chips first, then DBBM second, membrane third. So you see the first layer of membrane soaked in this BCM, so then it's very easy to apply. I don't need any fixation pins in a case like this. No need for that. You see, it only complicates the surgery. Pins are sometimes really nice. I'm going to show you a case at the end. And then you see here the double layer technique and the primary wound closure. So here you see the reopening at 8 weeks, provisionalization, and then you see this is the 3.5 years follow-up. The crown was made by Professor Belzer, and of course a new crown on the adjacent already crowned natural tooth. I mean, the outcome is just blowing. I mean, excellent. And so I have not seen the lady for 2 years now due to the pandemic, which doesn't live in Bern. So we hope to get her back. She would be close to 6 years. In January, I think, will be 6 years then already. So the documentation is very good. You see, we have a prospective 10-year study on 20 patients. That's one of them. That's the lady we showed in this paper of methodology. So you see here the whole procedure done in 2005. 2006, you see, I did all these 20 surgeries. Professor Benck did all the final crowns 10 years later. Of course, excellent outcome here. We also have, of course, longer documented cases. This is actually the first patient I treated in January 98, tissue level implant. This is a hybrid design implant, TPS surface at that time, but two-wall defect crater like this. You see the whole augmentation done, primary closure, 20 years later. Look, this one, 2018. So we're gonna see this lady again in 23 for 25 years. Look, the cone beam. This is the facial wall, fully maintained. She has an excellent home care. Look, the beautiful bone she has here. So this is the paper we published then with Vivian Chapuis. You see, she was allowed to publish our data of Professor Belzer and mine. You see, long-term effectiveness, Journal of Dental Research. None of the implant was considered a failure. Nothing lost. One implant did not have an intact buccal wall, as you can see here. So this is from a bone augmentation point of view, a failing procedure. So this implant is considered a surviving implant. The others were considered successful implants. And here you see from the JDR paper, you see the mean facial thickness was 1.7 millimeter, 10 years post-implant placement. This was not done with BCM because at that time we didn't know about it, but it's fine. See. We also did it successfully with two adjacent central incisors, which is much more demanding. See, then we augment always in between the two implants. Here you see the primary closure, and here you see then the final restoration done by Professor Belzer. See here, beautiful bony volume in between. That's most important for the central papilla because the thickness of the mucosa is only about 4 millimeters. It's not a real papilla. This is a scar tissue formation, you see. This is 11 years later, 2018. Huh? And look, beautiful, you see, beautiful augmentation here. Huh? And you see the thickness of the facial wall, not extra, you see, but again, this was done in 2000, I think, 7 or so. Okay, now that's a later case, you see 2016 or so, and you see this is now done with the full knowledge of BCM, so actually we used the same technique. That means we activated the BIOS with these TGF-beta-1 growth factors, and you see the whole procedure. 3 years later. Excellent. Look the facial walls. So that's what we see routinely today, routinely. And it has not become more demanding. We just learned, we got the understanding how these growth factors are working. So now when we go to the mandible, you see, here you see that's a healed side, 3 years post-extraction, huge flattening. And you see then often in the mandible, we have a different problem because the different problem is that we have an anatomy which is not in your favor. That means the gravity that has an impact on the bone fillers is your enemy, as I say, because the fillers tend to glide apically from the defect away. So that's why I show you this case. When the case goes back 2007 or so. So you see a very atrophic mandible. You see the implant bed was prepared, and then you see here a huge defect. So don't do it like this, because if you apply here fillers, then the fillers glide down here. So I always take this off for many, many, many years. So as you can see here, so I create a balcony and a lot of perforations to stimulate, of course, the ingrowth of blood vessels. So here you see now, you see that this is the defect we have. Then autogenous bone were harvested in the neighborhood, applied. And then we use a fibrin sealant, TIS-seal, it's called from Baxter. This is the combination of fibrinogen and thrombin to stabilize this. Then a second layer, DBBM, again, TIS-seal, you see, that's beautiful. And then a membrane on top and a primary closure. So that's the procedure in the mandible. That's one option, to do teeth seal. Look the case 15 years later. So the surgery was done 2005. Very nice outcome. Look at the tissue level implant, no sign of any crestal bone loss. And look the cone beam. So beautiful intact buccal wall, and you remember how much defect we had, at least 4 millimeters in height. So no wonder this is a smiley. So this implant is very happy. 15 years in place, 2020. So I did that also for the GBR book. So it's in the GBR book. Now, a more recent case, and that shows the other option, you see, and this is now what actually Istvan Urban had as an input to the market, also to this patient, to these treatment options. This is actually to utilize his technique called the sausage technique. I love to use it when it's necessary, because what he's doing, you see, that he's using fixation pins, and then you stabilize, and then you can overpack. And then, of course, the filler cannot go anywhere because it's stabilized by these pins. So you see that also in the posterior mandible, you see very unfavorable anatomy in the area 35 and 36. So in particular here, very steep. So implant bay preparation. Now we have used here narrow diameter implants. Otherwise, the exposed implant surface would have been outside. So then we take the bone off, very important. I took it off, so we get a balcony. And then membrane was placed and 2 tacks were used to stabilize it. And then you see now the defect. This is NNC implants of Straumann. Also narrow diameter implants, 3.3, and then autogenous bone, and then the second layer, and then the primary closure. So nothing can move. Primary closure. That's the 1-year follow-up. Then at the bottom, you see also with the GBR book, it's also in the GBR book, you see. If I recall correctly, this is 12 months later. The 2 implants are perfectly integrated, and look the augmentation result you have here for both implants. So here you see the capacity of a pin-fixated collagen membrane. So I do today quite often a sausage technique, actually staged approach in these very, let's say, narrow, very atrophic bones. Now, the last subject now, and we are moving, is about ridge augmentation with the staged approach using GBR. Here we talk about 1-wall defects, not 2-wall defects. That means when you place an implant, it would be outside the bone. And then, of course, when this is less than 4 millimeters, to prepare the implant bed is almost impossible. So actually, it's not a wise decision to do immediate, to do implant placement simultaneous GBR. It's better to augment the bone first, and so on. So, and we have done in these procedures many times staged approach using autogenous block grafts. So we published many papers, you see. We started in 1990, 96, 96, 2002, 2017. So we had 2 patient cohorts. Once we published 5-year data, that was 2002, and then we switched over to collagen-based membranes on top of block grafts, and then we started again. And then we published again with Vivian Chapuis, 2017. My patients and a few patients by Thomas von Arx. That was 2017. So that's the paper. You see, with 38 patients, most my patients, and you see after 10 years, a prospective study, you see we had 1 implant loss from 52, and we had a success rate accordingly of 98%. And the graft resorption measured by cone beam was 7.7%. So here you see one of the first cases I treated in 2002. See very atrophic mandible, you see very steep anatomy, a block graft, and then some DBBM and the collagen membrane primary closure. Then at reopening, at that time we were waiting 6 months. You see how well this block graft is integrated. We placed the 2 implants. Now 2020, also patient in the GBR book, you see, the implants are doing very well. You see here the cone beam, how thick the facial wall is from these block grafts we had. So this bone is completely revascularized and maintained the volume beautifully. The patient got now a new implant, but that's not shown here. So this is a case even longer. You see 94, this was with Gore-Tex block grafts. I remember that case very well. The lady is still alive. She's about 88 years old now. And she comes back to me from time to time. And you see here how we could place 3 implants, you see. And in 2010, 16 years follow-up with a new restoration, actually, I have to say, and so on. And here now you see 2019, that's 25 years post-placement. You see she's now 85. At that time, she's now 87. And look how these implants are doing. Facial walls are fully intact. Interesting that actually the prosthesis again has ceramic chipping. So that shows that implants are often doing much better than the restorations. But interesting now what I want to show you, and then we come to the conclusions. You see, when you look at this overall analysis of my department, you see from a first analysis, 2002, 2004, we had a total of 1,800 implants placed, and with GBR we placed 722, so 40%. 2008 to 10, it was 42%. 2014 to 16, we had already 2,200 implants with 972 implants with GBR, so 43%. In my last year, you see, as chairman, you see, we had 843 implants with 255, so we were down to 30%. Interesting. Huh? Then, how did he do the GBR? You see, in the first analysis was 17% staged approach GBR. In the mid-90s, it was more than 30% when we had only Gore-Tex. Then second group was 7.6%, in 14 to 16, still 7%, and in 2019, you see only 4% staged approach. That means we have reduced the morbidity for our patients dramatically. We do many, many more cases simultaneously. And now the question is, why is it that? For 2 reasons. First of all, we have a much better control about timing in post-extraction cases. Second, we have narrow diameter implants available which don't fracture anymore. And we do, that's the third one, which was not shown today, we do much more often socket grafting and place at 4 months of healing an implant without GBR. So these are actually absolutely the reasons why we have improved our treatment modalities for the patient. So with that one, I come to my conclusions. I think we are perfect in timing. I'm very pleased to see that. You see, the summary, what are the prerequisites for successful regenerative outcomes with GBR? You see, first, you as a clinician, you need to understand the tissue biology. So in particular, rich alterations post-extraction, very important. Second, you need bleeding bone surfaces for new bone formation. And therefore, 3-wall defects better than 2-wall defects, better than 1-wall defects. Third, you need appropriate bone grafts and bone substitutes. So when you do an augmentation with GBR, you need autogenous bone to foster the formation of bone in the early phase. And you need a low substitution xenographic bone filler for better volume maintenance. And the best one is BioOs. There's not even a dispute. Fourth, you need wound stability underneath the membrane. So the collagen membranes in a 2-wall defect is more than enough. Sometimes you need PTFE membranes or reinforced membranes, but this is a very small percentage. The second one is the membrane fixation, no tacks versus tacks or pins. So in my clinical experience, 5% pins, yes, 95% no need. And then last but not least, you need a tension-free primary wound closure. Don't underestimate this one, you see. Release the flap and get primary wound closure without any tension. So you need to understand reach alterations. That's in post-extraction implant placement. Most important to really analyze the patient carefully to make the right decisions. So case selection based on clear selection criteria is most important. Then in post-extraction sites, you have the different treatment options. I showed them to you only in the overview. I showed you only the one, the most frequent one. So the timing is crucial, no question. So you always should choose a treatment approach which offers you predictability for successful outcomes and a low risk for complications. And the treatment of choice depends on several factors. That includes the local anatomy, probably most important, but also age and medical risk factors of the patient. When a patient is 80 plus, I don't go for open flaps, whatever. I try to do everything flapless with socket grafting. The location of the implant, non-aesthetic aesthetics, and last but not least, your skills and your talent as a surgeon. If you are not a top surgeon, then I would not go for immediate implant placement, then go for early, because this is much less demanding from a surgical point of view. Okay, implant placement with simultaneous GBR, you see. This is done most often for early implant placement with contour augmentation. I'm sorry for the typo here. Let me fix that. I just see it. So this is not contours augmentation, it's contour. Okay, I often use it with capital letters because it's a term. Okay, I use this in post-extraction sites when there is a thin or a damaged facial wall. You must have the patient available at 4 to 8 weeks, so you can place the implant. And you need a 2-wall defect and a sufficient bone volume palato apically to stabilize the implant. Contour augmentation is done with a 2-layer composite graft, as I explained it, composite graft in 2 layers, covered by a resorbable collagen membrane, primary wound closure, and 8 weeks of healing, which is a routine, also early loading protocol. You see, the long-term results are excellent. The autograft chips accelerate only in the first 2 to 4 weeks the speed and the volume of newly formed bone, and then actually the bone doesn't play a role. DBBM plays the big role for long-term stability because it is not substituted. So it's osseointegrated within this bony mass, which forms like a callus formation in a fracture healing, and then it stays there. For long-term stability, you also need a patient, you see, who has a low-risk behavior. That means he should be non-smoking if possible and should have a good oral hygiene, using superfloss, and of course come to your dental hygiene appointments. Staged approach. You see, these applications could be significantly reduced in the past 10 years, as I explained it to you, because we have a better control of the timing post-extraction. We have narrow diameter implants available with good strength, rock solid, Straumann material, and we have membrane fixation pins, you see, because this is mandatory for sausage technique, also the Istvan Urban technique. Okay, we have good clinical success with autonomous block grafts, and I tell you frankly, when I have a ridge augmentation to do, I always consider sausage technique today because it has a reduced morbidity compared to the block grafts. Okay, so the key today is case selection. So you have all these different options, what I showed you, the treatments on post-extraction, then the treatment option at day of extraction, and then you have the different categories depending on the defect morphology, you see. So you need to examine very carefully. You need to have proper selection criteria, and then you should apply them wisely, you see, to have the best chance for successful outcome and long-term stability. So case selection is the key, and lifelong learning, because you see, we make progress constantly, and we should always go with the latest knowledge we have. So again, you see, if you're interested in more details, I can only encourage you, buy that book. The book is fantastic. See, because I'm so happy that we could get these top quality authors to contribute. I can tell you, you see, The royalties of that book goes into Buser Implant Foundation, which will be used to support young high potentials in the field of research and education of implant dentistry. So this is what we do. The same is with hybrid master courses. We have established during the pandemic to go for hybrid. And you see, I show you quickly here a summary of the GBR course. This GBR Master Course 2.0 was the best ever.
My impression is very positive because it is one of my first very big courses that I do, and has been an honor to be here with Buser and listening to all the amazing masters actually on the field. So for me, it's just like I'm very concentrating on the learning part, and I think I've gained knowledge by coming over here and by participating and by being able to ask questions.
I strongly recommend this course. Really, like I visited many places. I took many courses, but here they just like teach us evidence-based dentistry and the most updated information about implantology. Danny is a great teacher. He can easily give you simply the information so you can stick to your mind. Absolutely, I strongly recommend this place.
The 3 days are over. I'm very, very pleased and happy with the whole course. We had, you see, 18 lectures by top faculty. That included 5 international guest speakers, world famous, and the local speakers from Bern. Then we had 4 live surgeries that showed in 4 different clinical scenarios the complexity of GBR procedures. And last but not least, we had 2 hands-on workshops for the on-site participants. I'm very, very pleased, very happy about it. I thank all the participants from more than 40 countries with on-site and online participation to be part of our GBR Master Course. Oh, you see how excited I am. You see, we had a really nice GBR course, 2.0 I called it, because it was completely reorganized. And you see here the lineup of these fantastic speakers, all friends, very good personal friends of mine. Stephen Chen from the left, you see Ronnie Junger from Zurich, Frank Schwartz from Frankfurt, you see Shakil Shadat from London, and of course my buddy Istvan Urban from Budapest, you see. 11 speakers, 18 lectures, 4 live surgeries. If you go to our homepage and there is a special voucher code you can have via Geistlich or Geistlich 20, then actually you get a 20% discount. There are special rates for low-income countries, like you see. And so if you have a question, you can contact Flavia Affolter from our organizing office, bern/co.com. Well, with that one, I want to thank you. I think we were just on time, and I'm more than happy now to go into the questionnaires to explain some of the details of these procedures.
Danny, thank you very much. It was always a pleasure listening to you and watching you speak. It's obviously tough to have 30 years of experience into only 1 hour of lecture. And I think you did a wonderful job to give us an overview of what's happening here, what you put into this next edition of the book, and also your experience. I think the majority of this experience is the vast experience and knowledge over 30 years you have collected on this. And I think this is, you and your team is more or less the only one in the world that can have this amount of information on that one particular topic. So thank you very much for joining us. We have a couple of questions. Let me go through them here. First of all, we have many thanks and greetings for the presentation. That's a comment. one of the participants like to ask if you use a single or a double layer suturing wound closure.
Although I'm not using a double wound closure. I use often mattress sutures. If I have to really make sure that the flap is not pulling too much, then I use most often these days in the aesthetic zone, I use vertical mattress sutures, 4/0 the thickness, and then we close up the flap with 5/0 and the releasing incision with 6/0 sutures. In the mandible, the mattress suture is normally a horizontal mattress suture. And these mattress sutures are left in place for 2 weeks to keep the flaps together. So they mature well, and then at 2 weeks, the stitches are all gone.
Okay, thank you very much. I think that should answer that question. Here's another one. What do you think of the, I'm not sure if I pronounce that right, Ixos, the YXOSS custom-made titanium cage for ridge augmentation?
Okay, I don't use titanium cages. You see, I would have a lot of reservation for that, because this is actually, like, from my point of view, a step backwards, because they were tested in the mid-1990s and there were a lot of problems with it, you see, because first of all, they often produce soft tissue disturbance in the healing, and then you get an exposed titanium mesh, you see. Second is, these meshes, you have to go back in with an open flap procedure and take them off. So I would only see these meshes, you see, in extremely difficult vertical bone defects, and then it should be done by top master clinicians who are using it on a routine basis, you see. But in the indications I showed, and this is the huge majority of patients you have, because most of the implants we do today, about 70 to 80% are post-extraction implants. And if you keep the timing under control, you never get into these kind of problems. Then you don't need any, let's say, PTFE membranes or these titanium meshes. You use collagen membrane, and then you eliminate an open flap procedure, which is a huge advantage for the patient.
Interesting, thank you. Here's the next one. I would like to ask, what is the advantages of placing tissue level implant instead of bone level when you fully cover your implant by bone particles?
Okay, you see, the tissue level implants, I tell you frankly, when Straumann comes out with the next development, which are bone level implants with a machined top, then you could call that also tissue level implant, because I think the term is actually wrong. We should stop to use tissue level and bone level implants as a brand. We should call them hybrid design implants, because that's a terminology by Dennis Tarnow from 93. That means this is an implant with inside the bone a micro rough surface to improve anchorage, and on top an area where you have a machine surface. And why is that an advantage? You see, as a Straumann has a BLX implant, now comes up with a TLX, has a BLT implant, will come out with a TLT probably in 1 or 1.5 years. Because when you have such an implant, and you always get bone remodeling in the crestal area, you have to do everything to avoid that your micro rough surface gets exposed. Because if you get an exposure of that micro rough surface, the bacteria will find this surface. And then
Peri-implantitis.
And then the risk is that this implant will develop over time, not in a short term. But as I said, we go for long-term functional and biological success. Then you have a risk that a certain percentage will develop then an peri-implant mucositis first, and then peri-implantitis. And we all know how difficult the treatment of peri-implantitis is. So when I use bone level implants, as I said, we go 1 millimeter below the crest and build it up to have then the peak of the facial wall coronal to the implant shoulder. So then we don't get an exposure of this. When we use tissue level implants, we put the SLA surface below the crest and have the implant shoulder slightly above the crest. It's not a tissue level implant in terms of the healing modality, because it's submerged anyhow. And I have done that already in 1998 when we had only T2 level implants available.
Okay, thank you. When and how do you decide on when to do GBR alone or implant placement along with GBR?
Okay, see also, GBR alone, when I have a one-wall defect, then we do just a bone augmentation procedure. That means when you have a borderline case, so let's say you have a 5 millimeter ridge, or you have a ridge which is 3 millimeters on top, but the shape of the ridge might be like this, then I take the ridge down if it's in the posterior and improve my situation by reducing the crest. And then I measure, you see, what implant can I use? When I go for a narrow diameter, then I can still do an implant placement, simultaneous bone augmentation. If I see then, even with a narrow diameter implant, my implant exposed surface would be outside the bone, not inside the bone, then this is a little bit too risky to go then for a simultaneous GBR procedure. Then you open up the marrow cavity of this narrow crest and do a bone augmentation procedure, either with a block graft. That's the technique we have used for many, many years. That, of course, has a negative aspect then, and a morbidity where you take the block either in the chin or retromolar, or you do the Istvan Urban sausage technique, which is a mixed composite graft, because there you want to have the autogenous bone all the way to the membrane. And then he's using often then there a sort of a PTFE membrane, but all is stabilized with pins. So this is the selection criteria.
Thank you very much. It's not a question, but greetings from Sasha Jovanovic. He's been watching us as well. So he says hello. So I think.
Thank you. Thank you.
Good. What is your opinion concerning DPTFE membrane used in socket grafting and open approach technique in terms of volume preservation and gain of keratinized tissue? I hope I answered that or asked that correctly.
No, I tell you frankly, you see, I'm using socket grafting with great pleasure. But we have to stop that socket grafting procedure is 500 to 1,000 Swiss francs or US dollar before you even place the implant. So what I do actually, I do a socket grafting with DBBM collagen. And I take a little piece of collagen from a fleece, which is $10, and put it on top to protect the applied bone filler and do a cross ligature suture, and that's it. So I don't need no membrane. I don't need any, I don't know, one of these other substitutes, because I think we have to stop to constantly increase the expenses for the treatments, because when we do that, we are limiting ourselves only to patients who have a lot of money, and this is not good. So therefore, that's my way of treatment, and I'm very pleased what I see. Now, I have not done any studies on it because I decided 3 years ago, now I'm in an age that I have done enough research. So this is left over to the young generation now. And of course, there are multiple studies that show multiple techniques. We all know socket grafting works to reduce the amount of volume maintenance or the amount of volume atrophy. I think what we have to keep in mind, as we said in immediate implants, thick wall phenotypes for immediate implants is very suitable because it stables. It will stay there, you see. So for socket grafting, it's also important, is it a thick wall phenotype socket grafting case, or is it a thin wall phenotype socket grafting case? Because that explains these huge variations in the studies, because in most of the studies, this was not looked at. Now in the most recent one by Avila Ortiz, you see a systematic review, I think just came out a year ago, or even this year. They made the first time this distinction, and I think that's the way to do it. So I can only congratulate Avila Ortiz for his great paper.
Thank you very much. We have 2 more questions left, if you don't mind. I think you answered this one already, but you systematically use double resorbable membrane while
Yes,
performing GBR?
we are using a resorbable membrane. I use it in a double layer technique, but it's only one piece of membrane. So I take a membrane and cut it in two pieces. So then the larger piece is used in a vertical direction of the implant site, you see, and the second one goes to 90 degrees perpendicular. So then we have in the critical area where we have the defect underneath, we have a double layer technique. We did that out of a gut feeling from beginning when we started to use these membranes in 97, and it served us really well.
Thank you very much. And the last question for today is the critical thickness of the facial bone for immediate implantation, 1 or 1.5 millimeters?
Okay, for immediate implant placement, it is 1 millimeter. And why is that, you see? Because when you do immediate implants, then it's done flapless. So then you lose only inside of that alveolus, you use the bundle bone. And I tell you frankly, when I do an immediate implant and it's a thick wall phenotype, then I take the tooth off. And before I place the implant, I take a diamond drill of about 3 millimeters and I take some of the bone off inside this facial wall to eliminate the bundle bone, because then you don't get actually there then the activities of osteoclasts. So the 1.5 millimeter comes from another situation. You see, when you have a healed site and you do an open flap procedure, then of course you don't have any bundle bone resorption there because there is no tooth left there, you see. You have then a facial wall, and that can be 0.5 millimeter, 1 millimeter, or 1.5 millimeter. And here we learned from a paper we did with our group. You see, actually, the main author was Alberto Monche. The study was done in Spain. And then we could show, and that was actually a little shocking, you see that when the facial wall or the buccal wall was less than 1.5 millimeters, only 1 millimeter or 0.5 millimeter, the vertical bone loss in 2 months healing period was 3 millimeters. Now, what's the explanation? It's very similar to bundle bone resorption. Bundle bone means you get an avascular necrosis because you pull the tooth, you lose the blood supply of this bundle bone from the periodontal ligament. Now, when you have a healed site, then that bone on the facial and on the lingual is coming first from the periosteum, and it comes from the endosteum, from inside. So when you do a flap elevation, you are losing the periosteal blood supply. And when you put the implant in, you use the endosteal blood supply. So you have from both sides no blood supply anymore. And then this pattern is called avascular necrosis. So it's not reduced or resolved by infection, what we see in peri-implantitis. It is actually the bone becomes necrotic, and the osteocytes obviously do a signaling to the osteoclasts that they are necrotic. And then osteoclasts move in and take the bone off. So when you have a borderline case and you prepare the implant bed, and what I have shown you, you get these sharp-edged bony walls on the buccal. Take it please off and augment that bone, because this bone is going to resorb anyhow. And therefore I always take it off and do a bone augmentation with GBR. I do that for more than 20 years.
Thank you, Danny. I have one more question that just came in, which I think is quite interesting, at least for me as a layperson. What about GBR in the place of a lost implant after peri-implantitis?
Of a lost implant, after the implant has been removed. Yeah, but we do that all the time, you see. That means when we have, let's say, I remove more implants sent to me because of aesthetic disasters. That means exposed implant surfaces because implants are malpositioned. But the same is, of course, when you have a peri-implantitis and then it is so progressed that you have to take it off. Now, what are you doing? You take first the implant off to eliminate the infection if there is no chance to repair the case. And then what we do, also in an aesthetically disaster case, we take the implant off. If there is no keratinized mucosa, then I do actually, at day of extraction, of explantation, I should say, I do a mucosal grafting to get keratinized tissue back into that site. And then we analyze the case exactly the same way as I shown before. Is it a two-wall defect? How is the width of the defect? Can we go for simultaneous implant placement and GBR, or do we have to go for staged approach, or are there other alternatives than implant therapy to help the patient? You see, so same procedures.
Thank you very much. So I think with this, we are at an end. We're almost at 8 o'clock, so perfect timing. Danny, thank you very much again for your time and sharing with us your knowledge in this lecture. Also, everybody out there, please go and visit the Academy, the website I posted in the chat. It's not only great education, but it's also for a great cause. So with your education, you will help the next generation also to learn, if I understand correctly. So
absolutely, yes.
Please support that. Yes, and we see each other next year. The rest of us, hopefully, Danny, we will see each other also soon again in real life.
We will see each other in Boston. Yes.
Yes, perfect.
I'm gonna be in Boston for at least a week because I want to visit all my friends in Boston, Harvard, of course, where I still have an appointment, and then I will be able to go to Harvard. I might even go there after the Academy meeting because I will lecture at the Academy meeting in San Diego, and I'm gonna do also a one-day educational in San Francisco, and after that I go to Boston and visit my friends.
So for all the colleagues in the US or whoever wants to travel to the US next year, please join Professor Buse at the AO Academy, and then later in June in Boston. Perfect.
My pleasure. Give my best regards to your parents.
I will
the Dicker. I will never forget what kind of support I got when I was one of the youngsters, you see. I will never forget that. You see, as I never forget my mentors. You see, of course, primarily Andre Schroeder and Bob Schenk, both have been fantastic. Thank you.
Well, it's great that you give back this support for the youngsters now in a different way. So perfect. It's a circle.
It's a circle, absolutely. Okay, bye-bye.
Thank you, Danny. Thank you, everybody. And
thank you. And bye-bye.
We'll see each other soon. Bye-bye.
Bye-bye.